Ladies and gentlemen, and especially the chairman and Catherine, thank you for the invitation to be here at the Global Summit with so many people involved in this topic, so I hope for a fruitful discussion. I want to talk about the remaining challenges in F8, and you can think in the rest of the world, but even in the Netherlands. And Cascade screening can be of help. Yes. In the Netherlands, the systematic genetic family cascade screening program was going on since 1994. But unfortunately, until the 31st of December last year. So we are ahead of the rest of the world, but I think you will conquer us in years from now, because there is the risk that this screening will stop in the Netherlands. However, the Academic Medical Center, where John Kastelein and I am from, is taking it over. It's not going that fluently as when it is done by the Minister of Health, but we are doing our best, our utmost. Genetic fieldwork since 1994, so this car is from 1994, I think, and these field workers were as well. They went to the family in the home situation. There was an index case, and the rest of the family was informed that they could have familial hypercholesterolemia. So the technique is that you identify an index patient by DNA diagnosis, the index case, and you contact the index patient and ask if it's possible to do a house visit and visit the first-degree relatives. You collect samples, analyze familial mutation, and test cholesterol. So you identify new patients, and then you contact more relatives, second and third degrees. And hopefully you get this beautiful tree, but most of the time you get these types of trees. But anyhow, this helps you to find out if persons are at higher risk. And then you collect at the home visit the blood, and nowadays a swab for the DNA testing and the cholesterol testing. I'm doing not the right thing. So in between June 1989, when we start our pediatric lipid clinic in Amsterdam, more than 3,200 children were referred for a tentative diagnosis of primary hyperlipidemia. And I agree that we use different types of words, primary hyperlipidemia, autosomal dominant hypercholesterolemia, but I agree it's better, especially with this foundation, to call it familial hypercholesterolemia, even the FDB and the PCSK9 mutation. And the thing is, and I always show that in different symposia, why screening of children with familial hypercholesterolemia? Is this heterozygous F8 in childhood a disease or a disorder? I can tell you it is a disaster. And that's due to the fact that it's a 100-fold relative risk on a coronary event in between the age of 20 and 40. And since 20 years, I show this slide. 7-year-old boy, father died at the age of 27, having had his first myocardial infarction at 22, total cholesterol of 10, what to do? At first, draw a pedigree. Then you see that the brother of the father died at the age of 29 due to myocardial infarction, grandma 43 CVA, all three were smoking, and the happy thing today is that both the 7-year-old and the 9-year-old exceed the age their parent died. They were treated at a young age, so now they are older than their parents ever became. And the uncle, who also knows the mutation and is treated well, is already 50, suffering from the same 4.4 kilobase duplication. The boy has a total cholesterol of 10, HDL far too low, LDL normal values in between 1.7 and 3.4. I wish you all a lifelong 1.7 till 3.4, or it's in between 65 and 130 milligrams per deciliter. The second case is 10 years later. Father, 23 MI and bypasses. Grandma died of 56 MI. And for the first time, it was for me astonishing that in the same generation, a brother of 22 had an MI and a PCI. Both, again, were smoking. So smoking is something else that we need to do screening at a young age. Of the 3,200 children, almost 3,000 didn't smoke and none of them started. The 250 children who smoked, none of them stopped. So then you are too late. And smoking and FH is a badly combination. So I asked the 6 or 7-year-old, how many cigarettes do you smoke? They look with big eyes and say, nil. I write it in the medical record, and every year I repeat it with a high five, and so now none of them started. That is of great help. And even this year, it's difficult in the Netherlands to achieve that children are referred. Uncle, 32, died of myocardial infarction. Nephew, 26 myocardial infarction. Sister, 21 CVA, and 33 the second CVA. And the mother was not willing to test the children of 17 and 6 until she got at 31 her myocardial infarction and 4 bypasses. She was smoking, and the boys were not, luckily, but had high cholesterol, LDL of 7.8 and 9.4. When I look at the 2,000 pedigrees, 30% first degree relative already premature cardiovascular disease. Many of the parents are still too young to get these, or nowadays are well treated by the cardiologists and internists. 3/4 of the grandparents suffered from myocardial infarction, but in 1/4 it's not that obvious. Even in 10% there is no cardiovascular disease at all, as far as we could look. And if they had their infarction, the mean age was 38. If they died, the mean age was 40. So this is the slide you many times see today and tomorrow. Nordisk and many of us published in the European Heart Journal about the number of FH. Here we think we have 70% discovered in the Netherlands. But even in 2000, where in Hoofddorp, that is a city close to the airport, and God created Earth and the Netherlands created their own by building dikes. And in between these dikes, there is our airport. And there is a city now of 70,000 people, and he discovered that the frequency in that population was 1 in 232. He thought, because in international it was 1 in 500, this would be far too frequent, so he published 1 in 400. But in fact, yes, that's not a good idea. But now knowing that it's perhaps 1 in 232, with almost 70 million people and an autosomal dominant inheritance pattern, 72,000 heterozygous FH, and perhaps 60 homozygous or compound heterozygous FH will be in the Netherlands, not 33,000. And indeed, Barbara Schauke and our group recently published that 58 homozygous and compound heterozygous FH were found in the Netherlands. So she calculated a heterozygosity in the Netherlands of 1 in 240. And to look back to that slide, then we are perhaps not 70%, only on 35%. And Norway on 20%, and Iceland on 10%. And for the bottom, it's still less than 1% divided by 2. And so there is a task in the rest of the world and the Netherlands as well. But I come to that later. Here are the most frequent types in the Netherlands. And they are distributed over the country, but there are regions where they are more frequent. Nowadays, I hear more and more that perhaps the Netherlands is a special population where a lot of in-crowd or something like that, but that's not the case. We built the dikes, and the French came in, and the Germans came in, and the Spanish people, and the Portuguese. And finally, that's the mixed people now call themselves the Dutch. And even if we have more mutations, we will come to you, because the Dutch are traveling a lot, and they will bring their mutations to your country. So, in the meantime, next slide, yes. The amino acid sequence of the LDL receptor, we share it with cows, rabbits, hamsters, swine, sharks. So the receptor was assembled more than 450 million years ago. Yamamoto and Mechta figured out. So if you think it's a matter of just the Netherlands, dream on, sweet dreams. It's more a global problem. And here Derek beautifully shows that the real problem, of course, in childhood is homozygous FH. The threshold for CHD is at a really young age, and we heard of a 10-year-old who died just before LDL apheresis of, and here in the Lancet recently, a 5-year-old homozygous treated with cholestyramine, an LDL of 26, acute ischemia. You will miss the left coronary artery. You see the right coronary artery, left coronary artery is not there. There was a stent replaced and LDL apheresis, but died 3 months later of a second infarction. And Kurt Wiegman from Vienna recently published a 4-year-old boy, 20 millimole, atorva ezetimibe, died suddenly at age 4. 98% occlusion of the left coronary artery. You can see the 2% in the middle. There is the only option for the blood to go through. That's not an option. And they have these signs only in homozygous or compound heterozygous. The arcus cornealis at 6 o'clock is beautiful scene. And they will be LDL apheresed or liver transplanted. And here you see the LDL going down. But coming back to this publication in the European Heart Journal, and the Netherlands doing not that well, 35%, I can tell you the genetic screening was successful because it was even better than published. We now know that we had 5,422 cases, and via Cascade screening, there had to be screened 62,000 people, and 37% was positive. And there are 19,145 clinically diagnosed FH. So the total in the Netherlands already shall be 47,344. If it's 1 in 500, that's 140%. So we are doing really well. If it's 1 in 400, it's even 112%. So I think it's 1 in 244 or 232 or 1 in 200. And then we are at 60 or 65, 70%. Of children, we now know 10,790 children via Cascade screening, half of them positive, half of them negative. Is it possible to upload this page? I don't think so, but it's not necessary. If we look at the probable FH, and we do the DNA testing because the child is the product of the parents, as this t-shirt beautifully shows, then Joep de Vos is able to find the DNA in almost all children. We forgot to ask in 43, but in the other 2,290 children, we had a mutation in 93%, and the majority, 84% was heterozygous FH and 1% homozygous in children. And if we compare the LDL of the non-FH versus the heterozygous FH, the brothers and sisters, then you see, if you put them beside, that the LDL is more than double in FH versus non-FH. And if you put a standard deviation to it, the majority of the Gauss curve for the non-FH is below 3. And the majority of the Gauss curve for the FH is above 4.2 or something like that, 4.3. So if this is the ROC curve, one parent suffers from FH, then it's 98% chance of having heterozygosity in the child when the LDL is above 3.5. Then you will find an LDL receptor mutation. That's of great help. The other thing that is of great help is that Wald put the data of Kwitrovic. Peter Kwitrovic was one of the first pediatricians working on FH, and of Alpo Vuorio and my data together. And he found out that in between 1 and 9, that's the red dotted curve, the detection will be optimal without false positives. So in between 1 and 9, there is a real option. And he shows here this with the Gauss curves. And the cutoffs here are above are 5 and below are 4 and in between 4.5 for the LDL. That with an LDL of 5, you miss a lot of FH, but you won't get wrong with those without FH. So a false positive rate of 0.1%. And below, it's 1% false positive. So with Gerald and many of you, we published about screening and diagnosis. Use age, gender, and country-specific LDL-C thresholds for phenotypic diagnosis. And LDL cholesterol above 5 indicates high probability of FH in absence of a parental history of hypercholesterolemia or premature CHD. An LDL above 4 when there is presence of parental history of hypercholesterolemia. And we discussed yesterday that for the United States, we leave it by 190 and 160, although that's not exactly 5 and 4, that's 4.9 and 4.1, but for Europe, it helps to have it 5 and 4, and for you, 190 and 160. And reverse cascade screening, if one child with a normal BMI has an LDL of 2.6 and one sibling has an LDL of 5.2, that's bingo. That's almost 100% chance on an LDL receptor mutation. If they are from the same family, and if they have 3 or 4 children, and you do the tests of cholesterol in one family, and 1 or 2 or 3 have a high, and 1 or 2 or 3 have a low, that's definitely FH. So, but if you don't have genetic testing available, we published in Circulation, we excluded all those who were referred via Cascade screening with a high BMI, with a low cholesterol, with no autosomal dominant inheritance pattern, with parents with already established molecular diagnosis or with abnormal thyroid function, and 269 were left, and of them 95% proved to have a mutation. Only in 5% the mutation was absent. So, and these have somewhat lower LDL cholesterol, but even above normal. Normal is up till 3.4. So the conclusion of this is, if a child has a normal BMI, an elevated LDL-C, an autosomal dominant inheritance pattern, and normal thyroid function, you have a 95% chance on an LDL receptor mutation. To finalize, Cascade screening carried out initially in first-degree relatives, LDL cholesterol and or genetic testing. Use age, gender, and country-specific LDL-C levels, but I don't think they will differ that much, extend to second and third degrees relatives, and for genetic testing make cascade screening more cost effective, employed to screen family members after mutation identified in the index case. Over ideally to all index cases who have a phenotypic diagnosis of FH, genetic testing must be carried out in an accredited laboratory. If genetic testing detects a variant, its pathogenic significance needs to be assessed. And if genetic testing does not detect a variant, FA cannot be excluded, particularly if clinical phenotype is strongly suggestive of FH. I think we should start as early because we have to prevent them from starting smoking. And it becomes a lifestyle if they know it at an early age that they suffer from a genetic disorder. So they will adhere their drug for the rest of their lives. And this is recently published in the JAMA. After 10 years, now we can see the line of the FH children who started treatment between 8 and 18, whereas the parents already started to have their infarction, and it goes down dramatically. This green line goes now till 30. We hope to go till 80, 90, 100, 110, 120, 130, 150. Older than 150 is impossible. You get 5 billion heartbeats and you use 1 billion per 30 years. So there is an end, but we hope as late as possible. I want to thank my Dutch colleagues, but especially also Gerald, Sam, and John for the inspiring discussions lately. Thank you.